So today we are going to discuss about per abdomen examination, which will be dealt in inspection, palpation, percussion and auscultation again. So coming to the inspection, there are a few headings here which you have to remember first. For example, we have to observe for the shape of the abdomen and the symmetry, then observe for the movements of abdominal quadrants along with the respiration. Then any scar marks present, any sinuses and any visible veins which has to be examined in the standing posture. After that, we have to look for the flanks and umbilicus also. So these are few headings in the inspection. So we will go one by one. So mainly for the shape and symmetry, it is better to look the shape of the abdomen tangent shape like this. Or else you can also come at the foot end of the patient and carefully observe for the shape and symmetry. So if there is any discrepancy or any localized bulge, you can think of mass underneath that structure. So this is about the shape. So normally shape of the abdomen will be either flat or scaphoid. In younger age, there might be protuberance of the abdomen. But in ascites case, usually the shape will be uniformly distended. That you can comment like that. And after the shape and symmetry, you can mention about the flanks. So in case of ascites, usually flanks will be full. So that we can mention. After that, visualize the umbilicus. So in umbilicus, usually it will be inverted. Suppose it is everted or transversely stretched, we have to think of ascites again. In some cases, it will be vertically stretched. So in such cases, we have to think of pelvic pathologies. So this is about the position of the umbilicus. Then you observe for any scar marks that will suggest old surgeries, most commonly appendicectomy or laparotomy or some other surgeries. And if the patient is a known case of alcoholic liver disease or CLD, he might have undergone repeated ascitic tap, so that mark might be present. So these are related to the scar mark. Then visualize for the peristaltic movements. So if there is any obstruction, we will be able to visualize the movements over the abdominal wall that will suggest peristaltic movement, most probably intestinal obstruction. Then comes the like we can visualize veins, any visible dilated tortuous veins. For that, we have to ask the patient to be in standing position. So in standing position, mainly look on the lateral aspects, mainly over the flanks, lumbar area. Visualize for any visible dilated tortuous veins. So if they are present, it is significant. So this is inspecting visible veins. So this will complete inspection of the abdomen. Right. So then we will start with the palpation of the abdomen. Ideally, we will say after inspection, we have to go for auscultation, because by doing palpation and percussion in between, we will alter the bowel movements, which will again give a false perceptions in auscultating bowel sounds. So you can choose anything, but here in order we will go with the palpation of the abdomen. So mainly, you can come closer. Mainly abdomen is divided into 9 areas or 9 regions, we will say, and 4 quadrants. So first 4 quadrants are right upper quadrant, left upper quadrant, right lower quadrant and left lower quadrant. But for examination, it is important to know about the areas, that is 9 areas of the abdomen. So they will draw some imaginary lines. For example, 2 vertical imaginary lines from the mid-clavicular line. Then 2 horizontal imaginary lines. The upper one is at the pyloric level, they will say, transpyloric level. So that will corresponds to L1 vertebra or 9th costal cartilage. So that is transpyloric plane. One more is transtuberous plane. That is nothing but iliac tubercles will be there. So those points has to be considered. Just above the anterior superior iliac spine, some 1 to 2 centimeter above that, there will be tubercles. So in that area, we can consider another second horizontal line. So these things will divide the abdomen. This is considered as right hypochondriac. Then this is epigastric, left hypochondriac, left lumbar, then left iliac area. This is hypogastric or suprapubic area. This is umbilical area. This is right lumbar area and right iliac fossa. So these are 9 quadrants of the abdomen. So coming to the palpation as such, first we will deal it in superficial palpation, then deep palpation. So in superficial palpation, mainly we look for the tenderness. For that, gently observe for any wincing over the face of the patient in all these mentioned quadrants. So if there is, here mainly few things are there. One is tenderness, which can be visualized. Another one is guarding and rigidity. So guarding is a voluntary process. Whenever there is localized inflammation in the abdomen, patient will try to voluntarily do contraction of the abdominal muscles. That is nothing but guarding. Whereas rigidity is like whenever there is complete inflammation of the whole peritoneum, involuntary contraction of the abdominal muscles will be there. That is considered as rigidity. And if the rigidity is severe, like board-like rigidity will say, that is seen in any monoviscous perforation in which patient will be in too much pain. So this is about superficial palpation. Coming to the deep palpation, we have palpation of the liver and palpation of the spleen. For that, various methods they have mentioned. We'll deal one by one. First is classical method of liver palpation. So, usually we'll ask the patient to fold his legs. Otherwise, you can keep a pillow here and they can rest over that, so that abdominal muscles will be relaxed and the organs will be easily palpable. So we'll go with the liver palpation. Classical method, we have to keep whole of our palm. This is important, and our ulnar border, the border of the palm should be parallel to the border of that particular organ. This is important, and ask the patient to take slow deep breaths. ಮೆಲ್ಲಕ್ಕೆ ಉಸಿರು ತಗೋಬೇಕು, ಸ್ವಲ್ಪ ಹಿಡ್ಕೋಬೇಕು. Press and feel for the organ. Then go slightly above. Here one thing is, do not try to press inwards during inspiration because the abdomen will be moving outward. So it will cause discomfort to the patient. So if you are able to feel for the liver or any organ here, then we have to describe few things. That is, how is the border, whether it is sharp or like smooth border. And then we have to palpate for the surface also, surface of that organ. So whether the organ is firm, soft or hard. And in surface, are there any nodules? So these things has to be mentioned. And usually liver will be palpable around up to 3 centimeters below the right costal margin. So that is considered as normal. But if anything more than 3 centimeters, don't mention it as hepatomegaly here because it is not the complete liver span. So just mention liver is palpable 4 centimeters below right costal margin. So this is classical method. Then they consider another method as standard method of palpation. For that, what they will do? We can directly use the tips of the fingers at the right costal margin and try to feel for the organ, mainly at the height of inspiration. So if it is enlarged, it will come and hit below the tips of the fingers. This is considered as standard method using the tips of finger. Then one more method is dipping method. That is done in case of massive ascites. When we are not able to compress the abdominal wall only, in case of massive ascites, we can go ahead with that. So in such cases, what we will do? We will keep both of our palms like this and try to displace the fluid and feel for the organ. Displace the fluid and feel for the organ. Go slightly above each time. So this is dipping method of palpation of the liver. So these are few methods of palpation of liver. And coming to the palpation of the spleen, we will usually start from the right iliac fossa and we will go at an angle towards the spleen. So again, you have to keep whole of your palm and the border should be parallel to the border of the organ and go stepwise. Here we have to remember one thing, don't try to poke with the tips of finger, it will cause discomfort to the patient. Slight gentle movement should be there in this pattern. So if the spleen is palpable, we can just mention this much centimeters of the spleen is palpable below left costal margin. So as we know, spleen will enlarge in this tangential direction towards the umbilicus. Sometimes if it is massive, it will cross the umbilicus also. So that is about spleen palpation. And sometimes if there is only minimal splenomegaly, then we can consider other methods also. For example, we can ask the patient to turn towards right lateral position. So and gently give a pressure from the back side and try to feel for the spleen. So in case of minimal splenomegaly, we can use this method. And one more thing is, we consider it as hooking method. For that, you have to go on the left side of the patient and try to hook in between, like beneath the costal margin. If we are able to hook it, then there is no splenomegaly. If there is splenomegaly, we will not be able to do this hooking below the costal margin. That is one more method of spleen palpation. Say. Then about bimanual palpation of the kidney. So which is considered as palatable organ, which can be done using both of our palms. So thing in the palpation is about measurements. Few measurements are important in per abdomen. For example, we have to measure the abdominal girth, that is at the site of maximum expansion we have to measure. After that, the distance from xiphisternum to the umbilicus and umbilicus to pubic symphysis has to be measured. So any downward displacement will suggest fluid accumulation, or if there is any upward displacement of the umbilicus, if this distance is discordant, then we can consider pelvic organ pathologies. Similarly, we have to measure distance between anterior superior iliac spine and umbilicus on bilateral side. So it has to be equal. If there is any mismatch, we can consider that side pathology. So these are related to the measurements. Then if there is massive ascites for a long time, and if the patient is having ascites for a long time, there might be chances of weakness of the abdominal muscles, mainly rectus abdominis. That will lead to what? Divarication of the recti, which can be visualized in this method. We have to ask the patient to raise his head to look for any divarication in the upper part. Similarly, we can ask the patient to raise the legs against resistance. In that case, we can be able to look for divarication in the lower part. So we can do that now. ನಾನು ಇಲ್ಲಿ ಪ್ರೆಸ್ ಮಾಡ್ತಿರ್ತೀನಿ, ತಲೆನ ಮೇಲೆ ಎತ್ತಕ್ಕೆ ಟ್ರೈ ಮಾಡಿ. So if there is any weakness of the muscle, which can be visualized here. Similarly, we can ask, ಕಾಲ್ ಸ್ಟ್ರೈಟ್ ಆಗಿಬಿಡಿ, ಕಾಲ್ ಮೇಲೆ ಎತ್ತಕ್ಕೆ ಟ್ರೈ ಮಾಡಿ. So just give slight pressure over the legs, we will be able to visualize if there is any divarication. Similarly, the same method will help us to differentiate whether, suppose there was a mass in the inspection, it will help us to differentiate which plane the mass is lying. If the mass is beneath the muscles, that is in the internal organs, when we do such resistance movements, that mass will not be prominent. Suppose the mass is above the muscle plane, somewhere on the anterior abdominal wall. When we do such movements, the mass will become more prominent. So that will help in differentiation. Next, last thing in the palpation is, if there are any visible dilated veins, we have to look for the direction of the flow. I will demonstrate it now. So demonstration of the visible dilated tortuous veins. How to palpate to look for the direction of flow. Mainly over the flanks we have to consider. Here if any vein is visible, for example, first what we have to do, we have to milk it out. Milking method we'll say. Then we have to leave or lift out one finger and look for refilling of the vein. Suppose it is not filling, then do it again and lift the upper thumb or index finger, then look for the direction of the flow. Suppose it is filling in this direction, consider that. What is the importance of this milking method is, whenever there are visible dilated veins, see, the blood flow normally is upward above the umbilicus and it is downward below the umbilicus. This is normal drainage of the blood. And similar thing will happen in case of portal hypertension. Whenever there is portal hypertension, you will be able to see, when we are doing milking method, there will be visualization of the two different directions of the blood flow with dilated visible veins. Suppose there is superior vena cava obstruction, then once we do milking method, in case of superior vena cava obstruction, the blood flow of direction will be downward. So once we lift the upper finger, it will fill in this downward direction. Reverse happens in case of inferior vena cava obstruction. Once we do milking and lift our lower finger, then the blood will refill in upward direction. So that is suggestive of inferior vena cava obstruction. So these things are helpful in localizing the lesion again. That's all about the palpation of the abdomen. We'll go ahead with the percussion of the abdomen. In percussion, mainly percussion of any presence of the fluid, and then percussion of liver and spleen. So we'll start with the percussion. Mainly in case of minimal to moderate ascites, we will look for any shifting dullness. So I will demonstrate it now. For shifting dullness, we have to start percussing from the xiphisternum or epigastrium. percuss downward, it will be tympanic note because of the bowel loops. At one particular point, we will get the dull note. After that, we have to go one step above that. So it will be resonant. Then come laterally in the same plane. So at one point, we will get dull note again. Then we have to ask the patient to turn to the other side. And remember that we have to fix this finger here itself. So we have kept our finger here itself. Now wait for 30 seconds. Then the place where we got dull, again try to percuss there. It will change to resonant or tympanic note. So that is because of the shifting of the fluid to the other side. Again we have to keep on percussing till we get the dull note. Okay, so fluid has shifted from like this part to this part, that is shifting dullness. Okay, straight. Same thing has to be done on other side also, so that we will be able to mark the lower dull point and the lateral point and the lateral point on other side. So it will form a horseshoe kind of thing, in which shape the fluid will get accumulated. This is shifting dullness demonstration. Suppose there is massive ascites, then we look for the fluid thrill, for which we will ask the patient to keep his palm in the midline, and with one palm we will give gentle tap on one side, and with other palm we will be feeling for the vibrations. Okay, idu kai illi itkonತೀರಾ ಇಲ್ಲಿ ನೋಡಿ ಈ ಥರ ಹಂಗೆ ಇಟ್ಕೊಂಡಿರಿ. So we have to give a gentle tap and feel for the vibration. What is the importance of this? Like we have to ask the patient to keep his palm, because whenever we give a tap, there will be production of the waves or vibrations which will travel through two media. That is, one is fluid, another one is through the abdominal wall. So we are assessing about the fluid, not the abdominal wall pathologies. So we have to obstruct those waves by keeping this palm here, so that we will be able to feel the vibrations which are transmitting through fluid media only. So that is about fluid thrill demonstration. Next is percussion of the liver. For that we have to mark the upper border and lower border. So for upper border, we will usually start percussing from second intercostal space in the mid-clavicular line. So it will be resonant usually. At 1/5 or 6th intercostal space, we will be able to feel for the dullness. So mark that as upper border of the liver. Coming to the lower border, start from right iliac fossa. So the tympanic note will change to dull note at one point. So mark that point. So this will be the lower border of the liver. After that, we have to measure this span. Normally, the normal liver span will be 6 to 12 centimeter, we'll say 12 to 13 centimeter. Anything above 15, they will consider it as hepatomegaly. So this is about liver percussion. Coming to the spleen, there are various named methods in spleen percussion. Most common one is Trop's area percussion, which I have already explained in the respiratory system examination. So for spleen percussion, Trop's area, upper border will be the 6th rib and the lower border is left costal margin, and an imaginary line in the mid-axillary line which will join these two lines. So this will form a semilunar space. In that space we have to percuss. Usually it will be tympanic. If there is any dullness, that will suggest many pathologies. One of them is splenomegaly. This is Trop's area percussion. Other methods of spleen percussion are Nixon's and Castell's method. So in Nixon's method, what we will do is, in the left costal margin at midpoint, we have to mark the midpoint and we have to draw a perpendicular line. And in that line, we have to keep on percussing. So usually it will be dull for about 8 centimeters. Anything more than 8 centimeter is considered as splenomegaly. So this is Nixon's method. Then Castell's method, lowest intercostal space we have to consider, lowest intercostal space in the anterior axillary line. At that particular point, we have to percuss in two phases. One is inspiration, another one is expiration. Normally in both phases, we have to feel, we will get resonant note. Suppose if there is dullness in that particular lowest space in any phase, any of the two phases, you can consider it as splenomegaly by Castell's method. So these are few methods of percussion of the spleen. So whenever during exams, when we get splenomegaly in any of these methods, no need to do all these methods. If you get splenomegaly in any one method, that is fine, you consider it as splenomegaly with Nixon's method, for example. And coming to the grading of the splenomegaly, so up to 11 cm of the spleen is normal. As I just now told in the Nixon's method, 8 cm will be behind the ribs only, and 3 cm will be the normal added to that value. So up to 11 cm is normal. 11 to 15 cm of the spleen is considered as mild splenomegaly. 15 to 20 cm is considered as moderate splenomegaly, and anything more than 20 cm is massive splenomegaly, or if the spleen is crossing the umbilicus in the midline, it is considered as massive splenomegaly. That's all about the percussion of the abdomen. Then we'll go with the auscultation. Abdominal auscultation, mainly we look for bowel sounds, then any arterial bruit and venous hum. So these are the things. Coming to the bowel sounds, we can auscultate in the around the umbilicus using the diaphragm of stethoscope. So normally we will be able to hear bubble kind of sounds, which are bowel sounds. Normally, like in a minute, we can hear 5 to is hyperactive, which will be seen in intestinal obstruction or irritable bowel syndrome, etc. Whereas if the movements are less than 5, the bowel sounds are less than 5 in a minute, we can consider it as hypoactive bowel, which is seen in paralytic ileus. And suppose if you are not able to hear any bowel sounds, don't mention it as absent bowel sound, because we have to auscultate for minimum 5 minutes, they will say. So after 5 minutes of auscultation only, if we are not able to hear any bowel sound, then comment it as absent bowel sound, not just for 1 minute. So this is about bowel sound. Next is arterial bruit. So mainly, what are the reasons for arterial bruit? Any like turbulent blood flow in that particular artery. For example, in case of stenosis or any plaque, or there is any severe hypertension, we will be able to auscultate for arterial bruit. So mainly here few arteries are there which we have to focus. One is at the midline for aorta. Next is hepatic and splenic. Over the left and right hypochondriac region we have to auscultate. Then comes renal. Renal artery just above and lateral to the umbilicus 2 cm. You can auscultate on either side. So that is renal arteries. Then iliac artery, same 2 cm lateral, but below the umbilicus we can auscultate for the iliac artery. So if there is any abnormal flow or stenosis or plaque, we can able to hear that gushing kind of sound. That is nothing but arterial bruit. Coming to the venous hum. Venous hum is nothing but like whenever there is collateral formation in the veins. For example, portal to systemic collaterals. Then that again the flow of the blood will be turbulent. That is heard as a humming kind of sound. So for in our case, mainly portal hypertension we can expect in the case of cirrhosis. So for arterial bruit and venous hum, we have to use the bell of the stethoscope because they are low intensity sounds. So in the epigastric area, that is the site where portal and systemic veins will come and join. So you can auscultate at that area and comment about the venous hum. So this is about the abdominal examination. 9 areas, but there is something called as area number 10 in the abdomen, that is nothing but genitalia. So we have to examine genitalia also. Mainly we have to look for hernial orifices. If there is any prominence of hernial orifice, especially after the cough, that is called as cough impulse. So that is one thing, and we have to examine for the external genitalia also. If there is any atrophy, testicular atrophy for example, we have to comment about that, and if there are any structural changes, we have to mention about the genitalia. So this will complete abdominal examination. Follow this order so that we will come to a conclusion in the diagnosis of the abdominal system. Most commonly, the case given to us is cirrhotic liver disease. So follow this method. Thank you.